afternoon. So my name is Shira, and this is my colleague Olesya, and we're both fourth year medical students. So our case is titled Multiple Pneumothoraces Due to COVID-related Interstitial Disease in a Middle-Aged Female with AIDS. Next slide. Thank you. Okay, so our patient is a 59-year-old female with a past medical history of hypertension, hyperlipidemia, asthma, and HIV/AIDS, and she presents to the ED due to shortness of breath. In terms of her vitals, she presents with a low-grade fever. She's tachypnic, and her SpO2 is saturating at 93%. In terms of her physical exam, she presents with labored breathing and diminished breath sounds bilaterally. Next slide. Okay, so in terms of her lab findings and imaging, upon arrival, her ABG show a PO2 of 66. Her inflammatory markers are elevated. Her CD4 count is low, and in terms of her infectious disease testing, her COVID result came back as positive. And then on the right, you can see her initial X-ray image taken on 9/30. And it reveals hazy, ill-defined perihilar and infrahilar opacities, which suggest a multifocal infectious or inflammatory process. Next slide. So ultimately, she was diagnosed with COVID-positive acute hypoxemic respiratory failure. And in terms of her management, she was started on 2 liters nasal cannula, but throughout the course of her stay, she was upgraded to high flow nasal cannula on and off the non-rebreather during the day and then CPAP at night. For her COVID treatment, she was treated with remdesivir and dexamethasone. For her secondary bacterial pneumonia, treated with azithro and ceftriaxone. And to treat her AIDS, she was put on Biktarvy and Bactrim prophylaxis. Next slide. Okay, and so here we can see her clinical progression through 3 months. And as you can notice, the severity of the lungs does not change significantly throughout this course, yet her oxygen necessity throughout this time increased. And her clinical status continued to worsen. So there was this mismatch between her severity of the X-rays and her clinical status. So the physician performed a CT to determine the underlying state of the lungs.
Next slide, please. So we established a diagnosis of interstitial lung disease based on the results of the high-resolution CT that shows multifocal opacities, centrilobular, and 3 bud opacities, most prominent in the bilateral upper lobes and right middle lobe, and in our case, due to COVID-19 infection. Next slide. So here, we also highlight the clinical progression of this patient, starting at her first spontaneous pneumothorax in the right lung that started on December 18th. A day later, the chest tube was inserted to re-expand the lung, but due to malfunction of the chest tube, patient experienced her first tension pneumothorax on the right side just a few days later. And over the course of the next 2 weeks, she went through the vicious cycle of multiple pneumothoraces and tube insertions. And on January 3rd, she had a cardiac arrest and required intubation and mechanical ventilation. And shortly after, she succumbed to her illness. Next slide. So interstitial lung disease describes a large group of disorders, most of which cause inflammation and progressive scarring of lung tissue. So fibrosis is a feared complication of many respiratory infections, and one of which happened to be COVID. So we found COVID has been shown to induce pulmonary fibrosis in select patients, yet the major short and long-term complications are still being widely studied. The pulmonary fibrosis affects lung mechanics, that is about stiffness of the lungs and increase in the work of breathing. The increase in respiratory workload may be related to the frequent development of secondary spontaneous pneumothorax. And it is most often associated with poor outcomes due to limitation of treatment options, which consists of placement in the chest tubes and pleurodesis to prevent recurrence. However, Since successful pleurodesis requires physical contact between the visceral and parietal pleura, any disease process that would interfere with complete lung expansion, such in our like a trapped lung, such as in our patient, would lead to the failure. And usually the life expectancy for interstitial lung disease depends on the cause and severity. For people with the most severe and rapidly worsening forms, life expectancy is usually about 3 to 5 years after the diagnosis, as opposed to our patient who succumbed to her illness after only 102 days. And that concludes our presentation, and we can answer any questions.
I have a question, actually. Hi. I was wondering, did this patient, either prior to her death or post-mortem, did she get a tissue biopsy for histologic or for pathology or histologic analysis, or was the diagnosis just kind of, I guess I'm just wondering, do we know what type of interstitial lung disease she had or anything beyond just...
We're not sure about the biopsy because I don't remember doing the biopsy on her. But we don't know exactly what was a type of interstitial lung disease.
Oh,
It just all happened so quickly, and she was not the right candidate for the pleurodesis. It's just very progressive. She ended in the end of the clinical course, she ended up with 5 different tubes placed in both lungs.
Wow. Okay. Well, thank you. Interesting case.
Thank you.
Thank you.
Alrighty, thank you so much. Are there any other questions? Alrighty, thank you so much for presenting. We can go ahead and go on to the next presentation.